Assalamu alaikum. So, okay, fine. So this is the second of the lectures of neurosciences on my part, where I'll be covering the antidepressants. A little rejoinder to my first lecture. I know there are certain points which have not been covered in my Zoom session because of the limited time and late connection issues. So I will be covering that in the flashcard session, and Dr. Shazia will get in touch with you people and will set a date in the next week for the flashcards of the first week. A request for you is that I'll be uploading this lecture on antidepressant today on the YouTube channel, and simultaneously it will be there on your Moodle also. So it will be good if you just go through this presentation and hear the recorded lecture, and then we can then focus on to the points which are relevant in the Zoom session. The Zoom session tomorrow will be at the required time which is mentioned in the timetable, right? So tomorrow I suppose it is at 10:30. So at 10:30 we'll be there for the lecture. Fine. So antidepressants, what we is to explain the pathogenesis of depression, to describe the synthesis, degradation and reuptake of 5-hydroxytryptamine, to classify antidepressant and their mechanism of action, briefly describe and list the side effects of antidepressants, right? What is the symptomatology of depression and how does depression is different from mania? The symptomatology of depression is that the feeling of sadness, hopelessness, inability to experience pleasure in the usual activities, the activities which normally makes a person happy and feel pleasure, they do not experience that pleasure and happiness. There are changes in sleep pattern and appetite pattern, means either the patient may be eating too much or he may be eating too less, both the extreme, loss of energy and sometimes suicidal thoughts. In contrast, mania is an exaggeration of what? Enthusiasm. If you ask a manic patient to do something, he will do it as if he's got very less time and does with all his energy. Has anger, rapid thought and speech patterns. You can very well understand that this person is trying to go through the things very rapidly. Extreme self-confidence and impaired judgment. So that is why this is being put up over here, is because, say for example, if we give you a small scenario of the drugs, to ask about the drugs, so these are the points which will be covered in those lectures in those questions for once we are asking for depression, and we'll be focusing on these points once we'll be talking about the mania. So what is the main cause? The main cause is 5-hydroxytryptamine. What it is, serotonin being an inhibitory transmitter, stimulates nociceptive pain mediating nerve endings with 5-HT3 receptors. CNS, it accounts for 1% of 5-hydroxytryptamine of all the body. Just look at it, 1% serotonin of total body content, but involved in vital functions, sleep, appetite, thermoregulation and pain perception. Serotonin are necessary for a stable mood and to balance any excessive excitatory neurotransmitter firing in the brain. As a stimulant medication or caffeine can cause a depletion of serotonin over time. Serotonin also regulates many other processes such as carbohydrate craving, sleep cycle, pain control and appropriate digestion. How it is synthesized from tryptophan, being acted by tryptophan hydroxylase to form 5-hydroxytryptophan in the chromaffin cells and neurons, and where the decarboxylase in turn converts it to 5-hydroxytryptamine. And 5-hydroxytryptamine, once it is formed, you can see this in this diagram, the tryptophan being converted to 5-hydroxytryptophan by tryptophan hydroxylase, and then 5-hydroxytryptophan being converted to 5-hydroxytryptamine, which is serotonin, by the decarbylase action. Once it is formed, it is packed into the vesicles, and once these vesicles goes towards the margin with the process of exocytosis, they release the 5-hydroxytryptamine. So in the synaptic cleft, either the 5-hydroxytryptamine can bind with its specific receptors, the receptors being mentioned over here: 5-HT3, 5-HT2A, 5-HT1A, 5-HTT4. These are some of the receptors which it can attach to with their characters, right? So either one fate is that this serotonin, which is in the synaptic cleft, binds to its receptor. The excess of it is reuptake, is taken back by the nerve axon with the help of plasma membrane serotonin transporter. This is the SERT. Now this transporter is what is a main breakthrough in the treatment of psychosis and depression and so on and so forth diseases, because blocking of this transporter gives you a very big variety, and you have some of the very beneficial effects, and we will cover this more in detail in our subsequent slides. So what I've tried to mention: the synthesis of serotonin, the package into vesicle, its exocytosis, the two fate. One, either it binds to the receptors or it is taken up again by the nerve terminal, or it degrades. The degradation is by monoamine oxidase MOA, monoamine oxidase A. And there are two types of monoamine oxidase, and that also we will cover in our subsequent slide. So the three fates, either taken up by it attaches to the receptors, it is taken up back, or it is degraded. Being found in three places, the junk of serotonin is found in the intestine as enterochromaffin cells, which are endocrine cells, mainly in stomach, small intestine, and between the mucosal cells, some of them in myenteric plexus, where it acts as excitatory neurotransmitter. High concentration in platelets get uploaded with 5-HT serotonin, and they pass through intestinal circulation with high concentration and release when platelet aggregates at the site of injury. The CNS is present in and around the midbrain. In GIT, it facilitates peristalsis, secretion, and visceral sensitivity. SERT rapidly removes 5-hydroxytryptamine and thereby limiting its action. So SERT means the excess of the one transporter, the one receptor which takes back the serotonin from the synaptic cleft, and inhibiting that is used in psychiatry. Therefore, increase in 5-hydroxytryptamine in intestine and causes side effects of diarrhea. So this is an explanation that why 5-hydroxytryptamine or serotonin inhibitors, SSRIs, have profound GI effects. In large vessels, both arteries and veins, it constricts the large vessels with the help of this 5-HT2A receptor. And in 5-HT3, in the endothelial cells, releases nitric oxide, decreases noradrenaline, and results in vasodilatation. If damaged by atherosclerosis, it reverses to vasoconstriction. a variety of receptors of serotonin. As you can see, 5-HT-T1, T1A, T1B and D, 5-HT-T2, all of them with their sites and with their effects are mentioned over here. 5-HT3 are ligand-gated channels, inotropic, found in proxima region of medulla, which is involved in vomiting and other parts of the brainstem. An excitatory inotropic specific antagonist like ondansetron and treatment which is given for the treatment of nausea and vomiting. So 5-HT3 is the only ligand-gated cation channel or inotropic one which is of the 5-HT receptors. A mention of all the receptors with its specific sites. Coming over to the antidepressants, the main classification. So up till now what we have covered the synthesis, the fate of serotonin in the synaptic cleft, its degradation and the possible places where serotonin can have, and the different, we have a background knowledge that serotonin receptors are of many types and these types are very specific for each region. So inhibition or excitation of this or facilitation of these receptors will have a varied effect. So the main antidepressants class, the main class are the SSRIs, the selective serotonin reuptake inhibitors, the serotonin norepinephrine reuptake inhibitors, the 5-HT2 antagonist, or which are known as serotonin adrenaline reuptake inhibitors. We have tricyclic antidepressants, the tetracyclic antidepressants and the monoamine oxidase inhibitors. Now a word about tricyclic and tetracyclic antidepressants. They were the drugs of choice to treat depression before SSRIs were found. But once SSRIs were found, the scope of tricyclic and tetracyclic antidepressants is very much reduced, because the tricyclic and tetracyclic antidepressants, although they are very potent antidepressants, but they have varied and very large area of side effects. So those side effects are minimized by these SSRIs, the SNRIs and the monoamine oxidase inhibitors. So once you have a better option, so these tricyclic and tetracyclics are used in very select cases where the other ones are not effective. Sexual dysfunction, anxiety, restlessness, nervousness, insomnia, fatigue, sedation. Very little risk of cardiotoxicity and can develop a discontinuation syndrome with agitation, nausea, disequilibrium and dysphoria. Now, coming over to this part, that how does this really acts. So in this part, what we will be covering, what we are showing you in this at this stage is serotonin neuron in a depressed patient. In depression, 5-HT neuron is conceptualized as having relative deficiency of neurotransmitter. The number of 5-HT2 receptors is upregulated because of the deficiency of the serotonin. The receptors are more, including presynaptic 5-HT1A autoreceptors as well as postsynaptic 5-HT receptors. When you give an SSRI, it immediately blocks the serotonin reuptake pump, which results in excessive serotonin in the synaptic cleft. So when an SSRI is administered, it immediately blocks the serotonin reuptake pump, this one, right? And the serotonin transporter blocking the reuptake pump or the serotonin transporter. However, with this blocking, what happens? This serotonin to increase initially only in the somatodendritic area of the serotonin neuron left and not very much in the axon terminals. So it blocks all over the things. So what happens then? The consequence of serotonin increasing in the somatodendritic area of the serotonin neuron as depicted is that 5-HT1A autoreceptors desensitizes or downregulates in this area, somatodendritic area, the somatodendritic. Just compare this with this. Here 5-HT1A receptors were more, now here the 5-HT1A receptors gets less. With the result that once the somatodendritic receptors downregulate, there is no longer inhibition of the impulse flow in the serotonin neuron. Thus, neuronal impulse is turned on. The consequence of this is now the release of 5-serotonin in the axonal terminal. However, this increase is delayed as compared with the increase of 5-HT in the somatodendritic area of the 5-HT neuron. So, what we are trying to say, if I can summarize, this is the neuron of a depressed person. If you see here, the receptors are devoid of serotonin. Once we have given serotonin, once we have given SSRIs here, this SSRIs, they not only block this reuptake pump over here, they also block the reuptake pump in the somatodendritic area. Now, once this pump is blocked, this reuptake in the somatodendritic area is blocked. Normally, with this, there is less impulse to release serotonin. So once these receptors are blocked, as shown over here, it results in downregulation of these receptors which are there, and the inhibition is now released, and now more and more of the serotonin is released into the synaptic cleft as is shown over here. So all these events take some time, going over from this stage to the initial stage, and from initial stage to the intermediate stage, and the intermediate stage to the final one. So with this, what happens next? Finally, once the SSRIs have blocked the reuptake pump on SERT, increased somatodendritic serotonin, desensitized somatodendritic 5-HT1A autoreceptors, turn down the neuronal impulse and increases the release of serotonin from axon terminals. The first step shown here may be the desensitization of postsynaptic 5-HT receptors. This desensitization may mediate the reduction of side effects of SSRIs as tolerance develop. So, if we just try to concentrate on the main part. So, we started from here, right? We went over to this part that we have administered the SSRIs. It not only blocks the SERT but also blocks the autoreceptors at the somatodendritic area, resulting in release of the inhibitory effect on the release of serotonin, and there we have the excess of serotonin in the synaptic cleft, and finally we have got to a stage where this excess of serotonin now gives you less of this receptors which were initially very much. Now as these receptors are also inhibited, so the inhibition is gone, more and more of serotonin is released, these receptors are also become less, and once these receptors are less, only the required amount of serotonin is going to produce its effects. Excessive amount of serotonin will not be there, so the chances of side effects and tolerance will be going side by side. So as the tolerance develops, the side effects will become less. The antidepressant efficacy is similar to selection, is based on the past history of response side effect. There's typically a delay of 3 or 6 weeks. So if I ask you a question why there is a delay of 3 to 6 weeks before the therapeutic effect is achieved, so the explanation is the previous slide. If no improvement is seen after a trial of adequate length, that is about 2 months, and either you need to switch over to another antidepressant or augment it, you can have another group so as to achieve the desired response. As I have told you, the prototype of this group is fluoxetine. Fluoxetine, the half-life is 2.5 days, very long half-life, is well absorbed and metabolized into norfluoxetine. The pros: long half-life, so decreased incidence of discontinuation syndromes, good for patients with medication non-compliance issue. Long half-life and active metabolites may build up, not a good choice for patients with hepatic illness because of its degradation will also be affected. Significant P450 inhibition interactions, so this may not be a good choice in patients already on a number of medications. Initial activation may increase anxiety and insomnia. In addition to serotonin reuptake inhibition, fluoxetine has norepinephrine reuptake inhibition also, and serotonin 2C receptors antagonist actions. Fluoxetine's activating effects may be due to its action at 5-HT2C receptors. Norepinephrine reuptake inhibition may be clinically relevant only at high doses. So at the recommended doses, norepinephrine reuptake is not a significant issue. It only occurs if the dose is high. So preferably the serotonin, the SSRIs, the fluoxetine or Prozac is not given in a high dose. The other one is citalopram. You can just read it. It is just the same. It consists of 2 enantiomers, means 2 mirror-like variants. The R enantiomer has a weak antihistamine property and is a weak inhibitor of CYP2D6. Can be sedating and has a mild antagonism at one histamine receptor, explaining its properties of antihistamine. The R and S enantiomer are mirror images of each other but have slightly different or clinical properties. The escitalopram is the S enantiomer of citalopram, has been developed and marketed as antidepressant. Escitalopram more effective than citalopram in acute response and remission. It has got low inhibition of CYP450 enzyme, so fewer drug-drug interactions and intermediate half-life, not very long half-life. It has dose-dependent QT interval prolongation, so you need to be careful once you are giving it to cardiac effects. The common adverse effect of these are nausea, anxiety, drowsiness, insomnia, sexual dysfunction, and drug interactions. Points what we have already covered. Coming over to selective norepinephrine, the serotonin norepinephrine reuptake inhibitors, the SSRIs, they inhibit both serotonin and noradrenergic reuptake like tricyclic antidepressants. but without the antihistamine and antiadrenergic or anticholinergic side effects used for depression, anxiety, and possibly neuropathic pain. Venlafaxine and desvenlafaxine are the prototype of drugs. We'll discuss venlafaxine. It inhibits reuptake of both serotonin and norepinephrine, thus combining the two therapeutic mechanisms in one agent. The venlafaxine serotonergic actions are present at low doses, while its noradrenergic actions are progressively enhanced as the dose increases. It's converted into its active metabolite by CYP-D26. Minimal drug interactions, short half-life are its pros, fast renal clearance, unlike Prozac and fluoxetine, which have got intermediate and very long half-lives. The cons, the negative points, is that can cause 10 to 15 millimeter of dose-dependent increase in diastolic blood pressure, cause significant nausea, and can cause discontinuation syndrome and taper recommended after 2 weeks of administration. So you cannot stop this abruptly. Noted to cause QT prolongations, sexual side effects in more than 30% of patients. Monoamine oxidase inhibitors, the next in the class, bind irreversibly to monoamine oxidase, thereby preventing the inactivation of biogenic amines such as norepinephrine, dopamine, and serotonin, leading to increased synaptic levels, are very effective for depression. Side effects include orthostatic hypotension, weight gain, dry mouth, sedation, sexual function, and sleep disturbance. So you see the side effects are quite similar for each one of them. Now what can happen? Serotonin syndrome can develop if monoamine oxidase inhibitors are given with medications that increases serotonin and have sympathomimetic action. So because of too much of serotonin, what it can cause abdominal pain, diarrhea, sweats, tachycardia, hypertension, or delirium, and more. In acute cases, it can even cause hyperparexia and cardiovascular shock, leading to death. What can be done? We need to avoid, at least wait for 2 weeks before switching from SSRIs to monoamine oxidase inhibitors. A description about how does monoamine, there are two types of monoamine oxidases, monoamine oxidase A and monoamine oxidase B. The principal monoamine oxidase A is the one which we are more interested with, because this is the one which metabolizes serotonin, norepinephrine, and dopamine. Monoamine oxidase B also metabolizes dopamine, but it metabolizes 5-HT and norepinephrine only at high concentrations. This means that monoamine A inhibition increases 5-HT, norepinephrine, and dopamine, but the increase in dopamine is not as great as that of 5-HT and norepinephrine. Inhibition of monoamine oxidase A is an efficacious antidepressant. With monoamine oxidase B, they do not have antidepressant effect, because monoamine oxidase B metabolizes serotonin and norepinephrine with high concentrations. Since monoamine oxidase B role in destroying 5-HT and norepinephrine is small, its inhibition is not likely to be relevant to concentrations of these neurotransmitters. That is why they are not that very effective. Selective inhibition of monoamine oxidase B also has somewhat limited effects on dopamine, so it's not a good choice. Just mentioned here so as to you can have a differentiation and a different aspect of both. Monoamine oxidase A being the principal one which we use, and in that the histamine and norepinephrine are the one which gets more benefit than dopamine. Combined inhibition of monoamine oxidase A and B may have marked antidepressant effect owing to increase not only in serotonin, norepinephrine, but also in dopamine. Coming over to the next group, the benzodiazepine. The benzodiazepines are the ones which are noted for their sedative effect, and these are the ones starting from alprazolam, clonazepam, diazepam, lorazepam, oxazepam, and triazolam. So a wide range of this, and if you can just look at these trade names, must have come across people taking these tablets: Xanax, diazepam, Valium, and Halcyon, and Restoril, things so on and so forth. The main thing is that you see the dose equivalency. A minimal dose of alprazolam is required as compared to a hefty dose of temazepam. The other one which is important is the elimination half-life. You see, the half-life of Xanax is about 12 to 15 hours. So that means even if you take it once in a day, it will be more than enough, right? Look at this half-life, too long. And look at this, the shortest half-life. The benzodiazepines are basically divided on the basis of their half-life into long-acting, short-acting, and intermediate acting, right? This is of academic interest, but yes, you must know these two parameters, one as benzodiazepines are. You need to understand over here is that these two are the receptor binding sites for GABA. So benzodiazepine does not get attached here. Right? Benzodiazepine attaches to its another site. So it's something like different from this, but has got its effect same as this. This is what is allosteric modulation of GABA receptors. Benzodiazepine sensitive GABA receptors consist of 5 subunits with a central chloride channel having binding sites not only for GABA but also for positive allosteric modulators like benzodiazepine. When GABA binds to its sites on GABA receptor, it increases the frequency of chloride channels and thus allows more chloride channels to pass through. Chloride to pass through. When an allosteric modulator such as benzodiazepine attaches to GABA in addition to GABA, it does what? In the presence of GABA, the benzodiazepine will facilitate more and more of chloride ion movement. And what is done? So benzodiazepine receptor antagonist, we have, say for example, we have achieved excessive of sedation, right, with the benzodiazepine. So what we give flumazenil. What flumazenil is? It is a benzodiazepine receptor antagonist, is able to reverse a full agonist like benzodiazepine acting at its site on GABA receptors. This may be helpful in reversing the sedative effects of full agonist benzodiazepine when administered for anesthetic purpose or when it is taken as an overdose by a patient. So what we are talking about? We are talking about the antidote for benzodiazepine, or the drug which is used to undo the effects of benzodiazepine is flumazenil, which is a benzodiazepine receptor antagonist. See, the flumazenil gets attached to the site where the benzodiazepine would, and the number of chloride ions transfer will be decreased. The pathological anxiety, depression and anxiety Pathological anxiety fear may be caused by overactivation of amygdala. GABAergic agents such as benzodiazepine may alleviate anxiety as well, fear, by enhancing the phasic inhibitory action of postsynaptic GABA receptors within the amygdala. Agents that bind to the alpha and theta subunits of presynaptic norepinephrine PQ voltage sensitive calcium channels can block excessive release of glutamate in amygdala and thereby reduce anxiety. The amygdala receives input from serotonergic neurons which can have an inhibitory effect on some of its outputs. Thus, serotonergic agents may alleviate anxiety by enhancing serotonin input to amygdala. So what we have covered over here are 2 points. One is how does this SSRIs, serotonergic agent, may alleviate anxiety or fear. So serotonergic effect, SSRIs, anti-anxiety effects are because of its increasing the serotonin input to amygdala, right? And GABAergic effects such as benzodiazepine, it also can relieve anxiety by enhancing the phasic inhibitory action at postsynaptic GABA A receptors within the amygdala, right? And this is because of excessive release of glutamate in amygdala and thereby reduce anxiety. So 2 parts. First part is related to benzodiazepines, which are covered in these 1, 2 and 3, A, B and C. Whereas the 4th part is related to 5-hydroxytryptamine, right? So how does, if the question comes, how does selective serotonin reuptake inhibitors relieve anxiety? The answer lies over here. Because excessive serotonin available due to SSRIs has got an input into amygdala and thereby anxiety will be relieved. And how does benzodiazepine? It increases the release of, can block the excessive release of glutamate in amygdala. Right? So anxiety fear can be treated by 2 agents, benzodiazepines and SSRIs. SSRIs will do that by increasing serotonin in amygdala, and whereas the benzodiazepine will block the excessive release of glutamate in amygdala. Same effect, 2 different agents, 2 different mechanisms. Potential therapeutic actions of anxiolytics on worry. What are those effects? Pathological worry may be caused by overactivation of corticostriatal thalamocortical circuits. GABAergic agents such as benzodiazepine may alleviate worry by enhancing the actions of inhibitory GABA interneurons within the prefrontal cortex, and agents that bind to alpha 2 and theta subunits of presynaptic voltage sensitive calcium channels can block excessive release of glutamate and thereby reduce worry. In the prefrontal cortex, striatum thalamus receives input from serotonergic neurons which can have an inhibitory effect on the output. Thus, serotonergic agents may alleviate worry by enhancing serotonin input within the CSTC circuits. So, role of 5-HT1A partial agonist actions in anxiety. 5-HT1A partial agonists such as bupropion may relieve anxiety by actions both at presynaptic somatodendritic autoreceptors and at postsynaptic receptors. The onset of bupropion, like that of antidepressant, is delayed, suggesting that the therapeutic effects are actually related to downstream adaptive changes rather than acute actions of these receptors. Pathological worry may be caused by overactivation of CSTC circuits, specifically excessive noradrenergic activity within these circuits can reduce efficacy of information processing and theoretically cause worry. And how to overcome that? Delayed actions of NET inhibitors. Noradrenergic hyperactivity in CSTC circuits may be blocked by administration of norepinephrine transporter inhibitor, which can have downstream effects of downregulating beta-1 adrenergic receptors. Reduced stimulation by beta-adrenergic receptors could therefore lead to alleviation of worry. So, the role of 5-HT21A partial agonist is because of downstream adaptative changes rather than acute actions of these receptors, and hyperactive CST circuits and worry can be best dealt with norepinephrine transporter inhibitors. Norepinephrine provides input not only to amygdala but also to many regions to which amygdala projects. Thus, it plays an important role in fear response. Noradrenergic hyperactivation can lead to anxiety, panic attacks, tremors, sweating, tachycardia, hyperarousal, and noradrenergic hyperactivity is blocked by alpha-1 adrenergic blockers, which can lead to alleviation of anxiety and other stress-related symptoms like nightmares. And noradrenergic hyperactivity may also be blocked by administration of a norepinephrine transporter inhibitor, which can have the downstream effects of downregulating the beta-1 adrenergic receptors. Reduced stimulation by beta-adrenergic could therefore lead to alleviation of anxiety and stress-related symptoms. So the important anxiolytic and hypnotic agents on GABA and 5-HT21A receptors, you can find all over here: zolpidem, diazepam, flumazenil, and amobarbital. All have the plus ones. Flumazenil is the antidote, which acts at the benzodiazepine binding site, not at the GABA binding site. Bupropion is 5-HT1A receptor segment receptor antagonist. You can see the different classes of tricyclic antidepressants: the selective serotonin reuptake inhibitors and the atypical antidepressants, with their ability to inhibit norepinephrine uptake and inhibition of serotonin uptake. Examples are imipramine, amitriptyline, and doxepin, and clomipramine. Imipramine, these were the drugs which were used for quite many years until SSRIs came into it. The effects of tricyclic antidepressants: depression. How does it comes? And it SSRIs with 5-HT2C and with an NRI inserted. Side effects: weight gain, drowsiness, constipation, dry mouth, drowsiness. All these side effects are there with tricyclic antidepressants. Apart from that, they are very effective but potentially unacceptable side effect profile of antihistamine, anticholinergic, and antiadrenergic. Lethal in overdose, can cause QT lengthening even at therapeutic serum levels. side effects of antidepressants, tricyclic antidepressants, selective serotonin reuptake inhibitors, serotonin. So you see the minimal side effects are there with fluoxetine and paroxetine. Fluoxetine being the most darling of all these ones because there's very few adverse effects. And look at here, all with plus, 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 plus. The last one of them, the tetracyclic antidepressants, just mentioned here for the fact of covering the entire spectrum. It is an antagonist of presynaptic alpha-2 receptors and enhances the release of both norepinephrine and serotonin. It is an antagonist of 5-HT2 and 5-HT3 receptors. Potent agonist of H1 receptor, thus produce marked sedation. Different mechanism of action may cause good augmentation strategy to SSRIs. Increases serum cholesterol and triglycerides and associated with weight gain. This is the summary of the entire things what we have covered. So we have covered SSRIs, we have covered SSRIs, we have covered SNRIs, we have covered tricyclics, and so on and so forth. So all these things what we have covered monoamine oxidase inhibitors, this brings to the end of the presentation. I know that you people must be quite worked up after this presentation. The main points of emphasis for entire antidepressant activity. You need to know the 4 basic points which I have mentioned in the beginning. The synthesis of serotonin, norepinephrine, dopamine. The degradation of these things, synthesis and degradation. The receptors and their effects, and the receptors and their placement. Third, once you block these effects, say for example blocking SERT, SERT receptors, and then so on and so forth, their basic classification of antidepressants, the 5 or 7 classes, and prototype drug in each one of them. The most important of the groups, selective serotonin reuptake inhibitors, are by far the most effective and the most potent antidepressants. Serotonin, norepinephrine reuptake inhibitors are the second choice. Monoamine oxidase inhibitors are the third choice. Sometimes this third choice may become second, or the second choice may become the third. So these can have their replacement, but undoubtedly SSRIs are the main ones which you need to know. You need to know their exact mechanism of action, their exact receptors. The most important part, why these SSRIs takes 4 to 6 weeks to exert their full effect, and what will happen if you give a sudden stop of these selective serotonin inhibitors, reuptake inhibitors, and the difference between sudden stopping of SSRIs and SNRIs. These are the points on which you should consider, we should focus. I will be there on Zoom. I will not be repeating this lecture. I have uploaded this lecture on Moodle. My request to you will be that you must go through this lecture before we have a conversation. आप मेरा ये ऑडियो वाला पावर पॉइंट देख लें, रिकॉर्डेड लेक्चर देख लें, उसके बाद जब हम बैठ के डिस्कस करें, so we'll be having a short discussion and a crispy one. Okay, best of luck. Thank you so much. God bless you.